So Neal, do you think this concept that Dan just brought up of high volume versus low volume disease, greater than 4 metastatic sites, how successful do you, in your mind, have we been in terms of urologists in the community, larger practices, been incorporating that definition to make these decision points for the addition of other therapies to ADT?
So I think on one way I would answer it, I would say, completely artificial and arbitrary, and it makes no sense. And it's really limited by the inefficiencies of the scan technologies that we would use. But on the other side, I would say, well, the evidence only speaks to 4 or more bone lesions, and usually some outside of the axial skeletal as well, and or visceral metastases. So the evidence kind of, outweighs everything. But that said, as we get into more sophisticated scanning technologies, the absolute number becomes somewhat of an arbitrary issue. I was going to ask, given the breakthrough that we now have in ADT docetaxel 6 cycles, as no prednisone, interestingly, versus ADT abiraterone, reduced dose of 5 milligram prednisone daily, forest plots almost identical, all subplots beneficial. What do you do now, Dan, when a patient shows up, assuming they're fit for either docetaxel or abiraterone? How do you make your decision? And then what do you do after you go with one, and how do you think about sequencing?
It's a great question, and we don't have head-to-head data, so there's really no data that I can speak to say based on this I'm going to use abiraterone or I'm going to use docetaxel. But we have our own kind of clinical experiences, and for the most part, abiraterone is something that has been better tolerated in this setting. Although I will say there are circumstances where that's not the case. But starting out with an oral pill is something that we've been able to do. Now, this is not FDA approved in this space, so it's got NCCN criteria. There may be cost coverage issues, and that has come up in some practices. But for the most part, at least at Duke, we've been able to treat patients, and for the most part, we're treating patients with abiraterone. Where I've used docetaxel is in my patients with visceral mets, in particular with liver mets. When I have patients that have really dramatic disease biology, or patients where I've started abiraterone and I've not seen the kind of PSA decline in the first 2 to 3 months that I'm really looking for. Remember, the most prognostic indicators here are the rate of PSA decline and how low this gets. And PSAs that don't drop below 4.0 are particularly poor prognosis. We know that from SWOG and Maha's data.
And there's a nice paper in this month's JCO which actually follow up on that. We're looking at less than 0.2, 0.2 to 4, and above 4. Right. That's actually very predictive of bad outcomes. But I think your initial question was a really good one, in that your busy urologist who's seeing these patients can no longer just say, okay, I'm going to start you on ADT, I'm going to watch your PSA come down, it's all good. If you're not having this shared decision discussion about this incredible level 1 evidence to combine with ABI or DOCI, is really not doing the patient a good service. So I think that was a real important part of your question.
Yeah, so Alec, you obviously have created your business model in your clinic where you've incorporated a medical oncologist in-house. All of us, I think, especially in the urology world, are trying to drive to some element of standardization of pathways. How have you guys incorporated this data? Because again, these are the patients that are primarily showing up because they've been diagnosed in one fashion or another. They have to get a biopsy, so they're showing up to us. What's happening in Skyline in terms of the adoption of ADT plus one of these therapies, whether it be an oral agent or traditional chemotherapy?
So I think this really points out the importance of taking a multidisciplinary approach to this disease state, right? As you said, traditionally, these patients are in the urologist's office because they're referred to urologist, high PSA, urologist does a biopsy, and then the urologist is a physician who is now making all the decisions. And I would not be surprised that if there are still urologists out there who simply would start the patient on ADT. But obviously, in our practice, over the years, we've taken a multidisciplinary growth. Our group is probably really more of a multi-specialty group that's geared towards treating urologic disease. We have radiation oncologists, medical oncologists, pathologists. So internally, the referral process is much more fluid. And the education process is much more fluid. And their pathways are implemented. So the referral process is going by the pathway, although a lot of the pathway is not enforced, is really probably more suggestion. But because the knowledge is disseminated, and within our own group, we have ready availability of medical oncology expertise so that these patients are properly channeled. Because as you know, a urologist would, unless you're Neal Shore, you're not giving chemotherapy. And so oftentimes that is not really part of your armamentarium, which in this case really is a disservice to the patients.
So in your particular pathway at Skyline, if a patient does have just this setting, newly diagnosed high-grade prostate cancer with metastatic disease on bone scan CT, is the suggested pathway to then make sure that they see your medical oncologist at Skyline?
Absolutely.
What do you think the uptake is on that?
It's variable across, I'll be very honest, it's variable based on the individual urologist. I would be remiss if I didn't that there's a certain amount of inertia, stationary, hubris, but I think it's a slow process, and there are early adopters, quick adopters, and then there are those that gradually come along. But at least when you have a multidisciplinary approach within your own group, it allows for much easier adoption of that approach.
Gotcha.
And I would just add, and it's not all on the urologist. I mean, there are medical oncologists out there that are just not eager to see these patients or treat these patients. They're not going to necessarily give chemotherapy, and you can give the hormones, instead of me. So I think, but when you have a dedicated medical oncologist that is affiliated with your group, interested in this patient population, I think it really behooves us to work together. So I think finding those relationships, cultivating that when you can, and if it's there, use it. If it isn't, you can't blame the urologist for something they don't have access to. So, I think that's something that has to evolve on both sides.